reason. Perfect. Well, hello everyone, and welcome to our Roadshow 2.0. We have a nice number of people here. Welcome Adrian, Ihab, Ahmed, Jamie, James. Who else do I have? Kaylee, Sarah, Mel, Rovina, Trelly, Ben, and Tim. I'm not going to waste a lot of time. Today we're doing our second roadshow. We did the first one online a while ago. Then we did a fair bit of demo as well during our regional meeting. This is our second roadshow. We'll try to build on the stuff that we learned before. But we've learned something from the regional meeting is when it was interactive, it actually was much more informative and you really enjoyed it more. So while we have a prepared script and prepared cases, please jump in, ask questions wherever this takes us. It's really for you, not for us to decide what you want to see. In terms of other supports, some of you have already done their in-person training. Some of you have not. I think 16 of us, and there's another two groups going on today, have done their training. The rest is still coming. If you've done your training, you'll find this a little bit maybe easier to follow. Other supports I'm going to do, I'm going to send you an invitation. I've booked 3 days, Monday, Tuesday, and Wednesday before launch. I'm going to create an open Teams meeting for anybody to drop in. If they have questions, if they have, things they don't know how to do, whatever I can help with, I'm happy to, just so that you feel that you are, to the last minute, you can still ask questions and try to learn. Please make sure you sign up for your favorites fair. Rachel thankfully put the link in the chat. Kaylee, go ahead.
Is there how are we putting this on our own computers and stuff? Is there at some point do they teach us how to do that?
Yeah, it'll launch just like an app. Currently, we Citrix in from within the organization, but eventually it should be just an app on your desktop. Correct, Kyle?
Yeah, that's right.
There you go.
And is that there'll be sorry, is that going to be sometime soon? Because you were saying that we can play with it once we do our learning lab.
So the sandbox, I don't think it's live yet. There will be a sandbox within which you can play. I don't know, Kyle, is the sandbox coming before go live or after?
Yeah, it's coming this week. I was told it'll be here tomorrow for you guys, right. If not on Thursday, maybe.
Okay, and I'll make sure everybody knows when it's up. Ben, go ahead.
No, just jumping in to say that should be this week. We're just finalizing the communication.
Awesome. Okay. So, so without further ado, let's start. Monarch Prescriber Roadshow 2.0 for the emergency department. Do we have another slide, Rachel? I don't know who's sharing.
Nope, I'm sharing. Good morning, everyone. Yep, Rafi and I, as well as Kyle from Oracle Health, will be leading this roadshow. We just want to take a minute to acknowledge our Indigenous land acknowledgement. If everyone just wants to take a moment to read through that. So just a few quick objectives of today. We're going to be going into specific workflows, exploring some key scenarios, and I think if any of you have had your learning journeys, you'll have learned some of the functionality within the new system. I didn't make this slide deck. Someone made it for us. Like Rafi said, it's ED. If you guys have questions, put your hand up, stop us. Just come off of mute. Feel free to interact. It's easier that way. I'm sure if some of you have questions, the rest of you have the same question. I did put in the chat here the link for your favorites fair to sign up. These are the dates, 45-minute session. You'll work with one of the trainer, Fawad, I believe, and you can set up some of your settings. Just a few reminders. Sign up for your training, enroll in the classroom learning labs, and apparently physicians who have not completed training by the 9th will not be scheduled for these shifts for the last 6 weeks after go live. That's a little.
So I have to say, like, if we do not finish our training, we will not get our login, so we can't work. So it is really, really important. Like even myself, even Pam, we've spent months into this. You know, we I can probably train the class, but I'm still going to attend my training because, you know, I'm sure there will be aspects in there that I'm not familiar with. People have said they've used Epic or Cerner somewhere else. Still, the deployment might not be the same. The workflows will definitely not be the same. So please make sure you attend your training. Back to you, Rachel.
Nope, that's right. Again, just a little blurb that there will be at the elbow support for go live. I think Rafi's planning on being on site for quite a few days, as well as Ben. I saw his schedule. And then we will have our ED team, our Monarch ED team, and Kyle and Stephanie from Oracle Health there for the first week of go live. This is your CME evaluation. I don't know if anyone wants to take a picture.
Yep, let's do that now. Not yet. Okay. This is for today's CME, by the way, guys.
Did everyone get that? And does anyone need me to go back?
Yes,
I'm
please.
muted myself.
Just give me a second. I'll put it in the chat.
Thanks, Rafi.
If I can.
For some reason, I cannot see anything on my screen, whether you're sharing or stuff like that.
Oh.
So I'm not sure if I'm the only
Yeah,
one.
yeah, I think so. Can you just log off and come back in? It did the same to me when I first logged in. So try to log out and then come back in.
All right.
Thanks, Pam. Can everyone see my screen?
I can.
Citrix Workspace? Okay.
Yeah, and Katie's in as well. Welcome, Katie.
So this is FirstNet. This is the app that we're going to be going into. Right now, you can see that we're working out of the CERT domain. And then, like was mentioned before, hopefully this week we'll have the sandbox that you guys can go into and play. So once you go into FirstNet app, this is our ED launch point. This is our new tracker. I'm just gonna make sure I'm in St. Catharines.
Sorry, login with the same password as we currently use with the current system.
Yes, of course. All your credentialing is the same all across the organization. So when it comes time to work, your login is the same as login for everything else.
Okay, and then just jumping off of that, when we do start your shift, really important is that you check in. Your provider name will come up. You can put your initials in here, whatever you want to display on the provider list here. You're going to pick your role as the ED physician. You should have a default relationship as the ED physician here as well. And then you can pick your color. I think Rafi.
Well, Rachel, you and I seem to have the same color. I'm RFS and you are RC.
I don't think that's my color, but I think maybe you had grabbed it.
Okay.
So we're logged in now. Once we're logged in, you'll have to, because you guys are working off of laptops and not a station, you guys will have to make sure that you pick your location here. So whatever hospital or site that you're working at that day, you will need to make sure you pick it. If you're working off of one of the computers that are stationary, yeah, they'll be set to whatever site you're working in. So just a few quick things. I think you've seen this before. Your room columns. This has a few events and alerts that will pop up. You can see this patient's flagged for septic shock, EMS arrival. There are a few different things. This patient needs a reassess. This patient needs to be seen next. This is your CTAS level that's picked at triage. Your patient information, it has a bunch of different information, the age, There's no allergies documented on this patient. You'll come to know some of these icons. This patient actually has an allergy to Keflex and eggs, apparently. There's been an NPO order placed on this patient, a falls risk. This one has quite a few things on there. This is an infection risk that was flagged at triage, and then your physician billing, which we'll get into as well. This is the area that the triage nurse has designated the patient to go to. So these ones are APOD, RAS, see and treat. There's a few different ones depending on, this is a patient who's direct admit. Depending on what site you're at, the specialty column will change. This is super important, your provider sign-ins. So you can see we have our doctor, nurse, NP, resident, and then this is our EMS tech. Very important that you learn to sign up for your patients that you're going to see. So you can see here, go ahead.
Sorry. So this is exactly what I was going to say. So first, I changed my color. I'm now neon green. So you've got my favorite color. And the second thing is, this is extremely important. It's a very change right now. When we talk about a patient, whenever we discuss something, the way we attach ourselves to the patient is generally to take a sticker, right? But that does not really establish a relationship. While there will be stickers for us to take and generate like our own working list on paper, your relationship really with the patient is when you sign in, and you can sign in and sign off. So whenever someone talks to me about a patient that's in the tracker, before I do anything, I'll sign up for the patient, and then I will review the ECG. I will write a wet read on the ECG. I'll give an order if I have to. And even if I don't do anything, and if I say, Rachel, this patient's admitted, please talk to the MRP, and if you can't reach them in the next like 5 or 10 minutes, get back to me, and I'm happy to do whatever needs to be done, and then sign off. You can sign in and sign off for the patient. What that does, it immediately puts them on your list so you can find them later. You can document on them for whatever if you did something, and you can also bill them if you provided any billable services. So let's go ahead and sign up for A19.
Yeah, so this is our roadshow patient. You can see the nurse has already signed up, that triaged them, and then as the provider, we're going to assign ourselves. Very easy, like Rafi said, 2 people can sign up for the same patient. It just helps you, it puts this patient in the my patient zone here. Go ahead, Dr. Beecroft.
Sorry, what did you click on to get that? Did you just click under the MD or anywhere in that box?
It doesn't matter anywhere within this box because you're already signed in as a provider, as an MD. It's going to, you can see now I just clicked anywhere in that box, and then I can unassign myself.
What I'm going to do is I'm going to also sign up for A19. So there'll be 2 of us signed up, me and Rachel. Let me find A19, pod A. So I'm logged in as well to the system as second patients. Here is A19, and I'm going to assign them to myself. And if you see, there's a stack now. It's me and Rachel. There's both of us who are signed into the patient, RFS and RC.
That's right.
I can sign myself off, with the exact same ease. So I'm going to click. So I walked in to help Rachel with the resuscitation of this patient, and then I walked out. When I walked out, I unassigned myself, and if she refreshes her screen, it refreshes, I think, every minute, right?
Yeah, right now we need to refresh a little bit more
There
frequently,
you go.
but it
I
will
am
refresh.
gone. However, on my end, if I go to my patients, that patient is still on my list.
Yeah, and you can see here that I'm in all beds, but now I've put a filter on my all beds area. So this is all of the beds in the department. I put a filter on so I can see all of my patients that I've signed up for as the provider. And then you can also do the unassigned. So if you're looking to sign up for a patient and you don't know who hasn't signed up for a patient yet, you can click the unassigned filter as well. Super important that you look when you're like in these tabs. If you can't find your patient, you look at these filters to make sure you have the right one on.
My advice is always, once you sign up for a patient, always work from my patient tabs, the one that Rachel has 8 in, because that looks all across the department. So even if they're in the waiting room, even if they're not in a bed, even if you've signed up for them and they're sitting somewhere, it doesn't matter where they are. If you click my patients, that shows you everybody that you've signed up for that's actively in the department, regardless of location. So you're going to work there most of the time. You should only need to go to the other tabs if you want to find somebody and sign up for them.
That's right. So you can see here then too, I have still my patients filter on. And then below, I've also got the unassigned. So if I want to keep picking up more patients, I can do this. So like Rafi said, super important that anytime you interact with the patient, you want to set that PIA, you click on the patient. This is what your PIA is, and it's going to be tracked. And then there's a waiting room filter as well if you want to see patients who are in the waiting room. Otherwise, once you go ahead.
Go ahead, Pam.
Okay, thanks. Sorry, I forgot to raise my hand. So question again, for when you're interacting with a patient, do you sign yourself on and then you sign yourself off if it's not a patient that you will be keeping in your roster? Like, is that correct, Rafi? Because we talked about that, right? Like
exactly.
to capture that PIA. Okay.
Exactly. You capture the PIA, even when they're checked out in the checkout, they'll show up as your patient so you can find them later, right? So it's very important to sign on and sign off. You don't want to keep that relationship. Go ahead, Kaylee.
Are we supposed to then just add like a quick note somewhere? Is there some way to do just like a quick note without having?
Absolutely. So you're supposed to document everything you do for the patient. There is something called, when we get to the patient's chart and how you document, there's something called an other note, which is empty, and you can dictate 2 lines in it, right? I was asked to review the ECG of this patient. There's no ST elevations. He has a history of heart failure. I've asked for blood work and BNP, and I left his care with, Dr. Satrak, who took over as MRP. Which, if you look at patient's charts, that's the dictation I do when I see someone's ECG. When the triage nurse brings me an ECG, the next day you'll find a small dictation from me that says these 3 lines.
That's right. That's a good example. So I pull someone up to triage and I don't really like the way they look. I've done an ECG. I want Rafi to come and take a look at this patient. You would sign up for this patient. You would go to the ECG, do your wet read. You could do a quick note if you wanted to, and then you would unassign yourself from that patient if you're not going to continue care for that patient. So we have a lot of patients that we are signed up for as a provider. We're going to keep working off of this Roadshow 2 Emerge patient. This patient is, yeah.
I just want to ask people a question before we continue. I know this is the tracker. This is the replacement for our tracker. Does anybody have any question about the structure of it before we get into a patient? Is there a button you want us to talk about? Is there something you want us to show you before we move forward?
I think it would be helpful to go through the tabs real quick. Like if you think you have the time built in, like just hit every tab for a second and give us, just so our brains can see it.
Okay, so let me start, then let me do that and Rachel will follow me. So I'm going to start top to bottom, right? This is your tracker. The top part of the tracker, just under task, edit, and file, there are a lot of buttons. These are links to all kinds of things. So ED launch point is this tracker, but you can also go to a different places from here and come back to it by hitting ED tracker. Once we go down below exit and calculator, that's your ED launch point. So it starts at the blue. That is your actual tracker. The tabs at the top, there's a refresh button and there's a full screen if you want to go into full screen so you remove everything else. Below that, there are the tabs to view the patients in different ways. Like we have different trackers now, right? Unassigned ED, ED RAS patients, see and treat patients. These are the tabs at the top. The tracker works top to bottom. The patient's chart, when we see later, works, the hierarchy works left to right. So you can see your patients. You can click all beds. So all beds shows you everybody in a bed. Now she has my patients filter on, so that's why you only see, now it's off. You can add the waiting room to that tab. If you go to pod A, there's 13 patients in pod A. And empty beds, you can turn them on and off to see what beds are empty. RAS is the same thing. Offload is the same thing. Pod C is the same thing. And to any one of those, if you're there, you can add all the unassigned patients by clicking the unassigned filter. The reassess tab is important. So if you go to the reassess tab, it shows everybody for reassessment for everyone. And you can simply hit my patients to see yours. So if Rachel hits my patients, A16 will disappear and she will only see A or the other way. Oh, she turned what? Yeah. So you signed up to A16. I'm sorry. So only her patient remains there. So what you do is whenever you have reassessment, you can see them in my patients if there's a reassess flag. I do warn you though, the flags show up under the bed number, and some flags have a higher hierarchy. So if there's a sepsis alert, it will cover the reassess. So
and there'll just be a little tab, right?
Yeah,
There'll be like a
you
little
can
paper
toggle.
flip. So you
can toggle them. So that's why it's important to always check the reassess tab. So my guess is the way I will work is once I sign up for patients, I'm going to toggle between two tabs. My patients to see all my patients, what's happening with them, and the reassess tab where the nurse has assigned a patient to reassess. And yes, Trelly, go ahead. Trelly, go ahead. Unmute yourself. Yes, please.
Okay. So if you have a resident, when they sign up, they're on their own computer. How does their name, like how do
so they sign up for patients? Yeah, so they sign up for patients as well, but they're not the main provider we audit under MD, right?
Oh,
there's
is
a
it
column for resident. Yeah. Okay,
That's
I'm going to go down and you will see how it works. James, go ahead.
Okay.
Just quick question. How are these, like we're seeing them in order? Are they in bed order right now? Is there a way we can put them in time order? Like
yes, you
normally
can
we
sort
have
them
our
out just like an Excel file. If you take a look at the top, most of the top titles for the icons, for the columns, if you hit them, it'll sort out according to that. So you can sort by length of stay, you can sort by name, and you can sort by bed.
Can you
That's length of stay.
Can you please like just hang on to that mouse where you are because I don't see it.
Oh, she's
This
on
one,
length of stay.
Yeah, sorry, I didn't see.
before
Length
now.
of stay was way over to the
there
right
you
hand
are.
side. I didn't
Okay.
even
Yes,
see
it's
that
at very
before.
end.
Sorry, thank you.
There you go. Thank
Yeah. And you can sort them by bed number, you can sort them by patient name, last name, whatever way you want. Okay, there's a checkout, so we're staying with the tabs. The person with a plus on it, that's a quick add to the tracker. We don't usually use that, right, Rachel? That's for swipe, for quick look.
So this button for you guys specifically is going to be if you had a provider like a family doctor who
okay.
said, I'm going to send my patient in, and you just kind of wanted to quickly add them just as a note that you're adding a note. They still have to swipe into the department and be triaged, etc.
Great point. So pre-arrival, you know, when we get a call now when the information goes nowhere, if I get a call from somebody from DI and they're sending in a patient, I can add a pre-arrival, add that patient, put a couple of lines in. It will sit in pre-arrival, and when the patient registers, they attach that pre-arrival to the patient and the chart. It goes as part of the chart. So this is what you fill in.
Sorry, Rafi, can you just go back and show, because sometimes I'm not able to see where you're toggling.
Okay. Cancel.
Yep.
Thanks.
We are at the tabs. Extreme left. There's a person with a plus sign on it. Add pre-arrival. And now you can put in any information that you want. And once you okay it, it sits in a pre-arrival lounge. And now when they're triaged, that pre-arrival can be merged with the chart.
So we could use this probably for callbacks for sepsis and blood cultures and stuff.
We're going to get to that later. That's like 4 roadshows ahead. Adrian.
Perfect.
Did you want to go to the checkout tab?
Yeah. So checkout tab is your last tab when the patients are discharged, right? And you can filter it by my patients, and you can filter it by time frame.
Not just discharged, but they've actually left the department. These are patients where they've come off the tracker, and then you can filter it by my patients. So if you wanted to go back and do some documentation, or you can also look at different hours, 72 hours, or you can customize if you know a day that you saw this patient and you wanted to go back and continue doing some documentation. Every single patient lives here that's departed. So this will start to get busier. So you will want to use like the My Patient filter. My Unassigned Notes. Lots of different filters here. You can filter by the disposition.
Great. So let's go back to My Patients. Now, step down from the tabs is your filters. Right, My Patients, unassigned, waiting room, critical. So you can only filter if you have a lot of patients. You want to see if there's any critical results. You can click that, and anybody with a critical result will just show up. So these are your filters. Below that is your column titles. And you can see that you have the room, then you have the CTAS, patient info, designation, who signed up, some details there, your vitals. Now, your vitals you can collapse or not. So let's collapse the vital by clicking that little triangle. And then this column after vitals is very important. These are tasks for you to do. And the tasks for you to do mostly are of two types. Either you need to co-sign an order, or you need to reassess a patient. So that will also show up. And if you take a look here, you have 3 orders to co-sign. And if you click on this, it'll take you straight to where we want to go and co-sign them. Okay.
So, hang on a second, open up my other screen. You can see that this patient had verbal orders that were placed, sodium chloride and some ondansetron. And because they're verbal orders and the nurse put them in, they're going to click the provider's name and they're going to click that it's a communication type of a verbal order. Your medical directives won't route for co-signature.
Let's co-sign it so that they see what happens.
So.
Oh, it's still thinking.
So is the verbal order still actionable, just pending our signature at some point?
Yes,
obviously.
That's right. It's already, and these meds have already been given. So we'll just go ahead. You've reviewed them all. Click, click, click. Select all, deselect all, and then co-sign. And then this patient also has a See Next event on them that the nurse placed. So you can complete that right here. It would be the same for reassess.
What's the See Next? What's the See Next?
See Next is, yeah. Well,
oh, yeah, okay.
Or like I have a patient that I want as a priority.
I want you to come.
Yeah.
Okay. Now, here is something I want to say, guys. So do you see those tasks? This is also how nurse workflow is driven. So everything you order gets routed to the person, or supposed to be routed to the person who's supposed to execute it. And that's how they show up on their tracker as tasks. So things that need to go to a clerk will go to a clerk. The things that need to go to a nurse will go to a nurse. And that is why it is very important that everything you do as an order through your tracker. Because that's how it assigns it to the person who needs to do it. And not just that, it makes their life so much easier. So if I ask for an ECG by an RN, it goes to the RN to do the ECG. When she clicks on that, or he clicks on that task, it'll take them to where they're supposed to document. So it makes everybody's life easier. And that's how workflows are routed through different people, different members of the team. And then you have different columns that are drugs, labs, ECGs, DI, consultation, patient care and consultations. These are all kinds of things you've ordered and where they are in their progress cycle, right? Nothing has happened. The green, they're all done. I'm guessing 19 has something that is completed in the labs and is critical. Am I correct? That's why it's red?
That's right. And it's green because it's complete. Go ahead,
completed.
Pam.
So go ahead, Pam.
Yeah, sorry. Just going back to the See Next, would there be a note from the nurses to tell us why they want to see, to have the patient see next? Because in order to just make sure that we're not interrupting the workflow, what would be the indication to say, okay, you must see this patient next? And would there be a note from the nurses, or just like the clicking See Next?
So the nurses we skipped over this a little bit, but you can add comments here either by the physician or the staff. So I don't know, sepsis alert. You could add notes like that. This doesn't live within the patient's chart. This isn't going to negate, verbal communication either. I think the reassess tab is going to be used quite frequently. I don't know that like the See Next one will, because we do have so many of these alerts now on the patient. And then we also have a priority event that can be set as well.
So let's take a look at that critical results. Can you click on that critical results, Rachel? Let's see.
Yeah, so I was going to say any of these you can click right into, and it's going to bring you to a bit of a summary. So this is the labs. You can see here this patient has a glucose of 29. And then right here is your launch point favorites. So let's say you wanted to reorder a capillary glucose. You can reorder them right here, and then you can sign it, and it's going to route to the nurse as one of the tasks to go ahead and do another cap.
No,
sugar.
Sorry, go ahead.
Yep,
So
you're fine.
Sorry, here on this screen, on this order favorites, that bottom part is the department order favorites that we built, but that CBC up top is a personal order favorite that you guys will set during favorites fair, or come go live when you're customizing your preferences.
So what I want you to do, guys, is take a mental look of this window of what it looks like. Okay, and let's close it. Now, this patient, you can also access the patient information by clicking under their name. Can you click there? Exactly. And now this is the patient summary. This is where you will, so usually most of us, the way I work, the way Tim works is we look at the patient, we look at their summary, we look at the triage note. Usually we look at once we've signed up for them, we'll look at their previous history. So this is your sort of first look at the patient. It gives you the patient information, their latest vital, their home medications, their triage. And if you hover over it, it'll show you what's in there. Take a look. Triage objective. There it is. Uncomfortable and is grimacing. Skin is clammy to touch. You have your history. You have their active problems, some historical problems, some other information on the side. So you can see a lot of patients' information before you enter the chart. Of course, at the top, you can always open the chart or do orders. We're not going to go there yet. Now, do you remember when I asked you to take a look at to keep in mind that what the results of the labs look like? Notice that this is exactly the same window. The tabs at the top, let's click the labs again. That takes you to the same labs of the same patient. If you click the vitals, it'll take you to the vitals of the same patient. If you look at the patient care, so on and so forth. So you can enter this in a variety of ways. And once you enter it, in places where you can order stuff. So let's look at medications, for example. We have picked up the most common 15 or 20 medications that we think you're going to order in the ED, and we've put them right there for you. You can add your own favorites, but this is one way to order things without even opening the chart of the patient. You can see something here, you want to react to it. If the order's in the favorites, you pick it, you sign it, and you move on. James, go ahead.
Just a quick question, only because you kept going back on labs. Where are the normal ranges for all those tests? Because I've done this a long time, but I wouldn't say that I can remember what they all are.
It is, I don't know. It'll probably be flagged if abnormal, right?
Yep. So if you, this one is abnormal, and then if you just hover over, you can see normal here.
Excellent.
But
That's
also,
perfect. Thank you.
Anywhere on here, you see there's a blue hyperlink. If you click on that, it's going to take you to something called results review. This is within the patient's chart. It takes you right to your results review. Super important. Everything's going to be, your assessments are going to be here. Your DI is going to be here. Your ECGs will live here. So it's just that quick hyperlink. There's a lot of different ways to get to the same spot within the system.
What's the easiest way to trend things? Because as soon as we see an abnormal result, we want to trend it.
So it will trend here. You can see these patients obviously just don't have a whole lot of data on here, but you can also trend it in the results review. These will be added, right? You're going to continually add, and then you can change the date up here for your search criteria. So this is a brand new patient. They're not going to have any other information, but I can show you on maybe some of our IT patients where we have more data.
Sarah, fire away.
I'm guessing all the data from the EMR we have now will also be uploaded to this when we launch, right?
So I asked the same, sorry, go ahead, Rachel. You answer the question because you know the answer. I don't need to.
Last 5 years is my understanding. The last 5 years is going to be pulled from Meditech.
Awesome.
So last 5 years is going to be there hopefully by opening, by launch, and I think they're going to add more after. And Meditech will remain as a read-only for really historical data that does not get transferred. Am I correct, Ben? Because Ben is the ultimate authority on this. Charlie, fire away.
Oh, just quick, like when we're ordering something, say you want to order CBC or hemoglobin at 0600, is there a little thing on the order that where
yes,
you can
there is.
to order it, something?
Yeah, do you want me to go ahead and place some orders then?
Yeah, like if like
Okay,
it's
let's do that.
it's like you do it now or something, but say you want it in 4 hours if you're tracking a hemoglobin or something. How do you?
Great.
So you can, right from here, you can open the patient's chart.
Let's not do that. Let's not confuse them yet. Let's hit complete CBC.
Well,
from
this
here.
one here is going to be done now, right? Because the
Nah,
order sentence
you're
is
gonna click the basket and then you can change it, right?
You can.
Yeah. So notice whenever you add something, it goes to your basket and your basket turns green. And you can collect multiple things, right? I can collect 2 labs, an X-ray, a patient care. They all collect, and then I still have to go and sign them. It's at the bottom. It's easy. If you hit sign and close, it'll sign this and close the window. And if your order does not require more information, it'll sign it and file it and send it. If the order does not if the order requires more information, say you ordered an X-ray or a CT and you need to add some history, it will take you to the orders page. You can get there by clicking the green basket as well. So if you click the green basket.
I just want to point out though, Rafi, so when these have an order sentence attached to it right now, it's actually going to take you right to that order. So you can't modify from here. You'd have to go to the orders.
I have to. So if I hit green, I can't modify?
No, no, not from this basket here. You can, yes, when you if you ordered it from your
I have to go to orders. Got it. Okay. Okay. So let's go to orders. Why is it not liking? Oh, he's going there. Okay.
It's because I had orders in there that weren't signed yet.
Oh, okay. So let's go to the.
So this is where. Yep.
Yeah. Let's go to the basket. Okay, let's stop here for a second.
Okay.
So before we continue, can you close that just for a second? Can you just okay. So you can order things from all kinds of places. You can order them from the tracker. You can order them from here, what's called ED quick orders, and we'll show you how to get there. You can order them from the ED provider chart. You can order them from anywhere that says orders. Eventually, you will get to a central place where orders are that you have to modify and sign your orders. And this is what we're going to get to. So we're going to order the CBC that Trelly wanted. It goes up in our basket. We're going to click our basket. Now from here, you will get a couple of options. Sign, modify orders, remove it, cancel it. I will tell you, I've worked with these order sets a very long time. I will always go to modify details and not sign directly because there's always something that I need to do. I just want to have a final look before they fire away, because once they fire them, they're gone unless you go and cancel. So if we click modify details, it will take you to this orders page. Now, I want you to take a mental image of this page, because this is where you're going to end up no matter where you started from, no matter what ED order sets you used, you're going to end up in this. It will contain all your orders that you've ordered and all the orders that you still need to sign. When I get here, this is when you can click on any order and modify it. So let's modify the CBC. When did you want it, Trelly? 4 hours from now?
I don't know if say I want it at 0400, but
there you go.
Do you have to do like in 6 hours? Can you just
so here it is. Look at where her so this is going to have collection date, and you're going to do it today at 1200.
Okay.
But you can also do it here and just change your frequency. If you want it to be like every 12 hours, you can change the frequency here as well.
Thank you.
So you can change all the parameters of any order once you open it in this window. So let's go ahead and sign it. And done. Now you've just ordered a CBC at 1200. Thank you, Rachel. Let's go back to our tracker.
So again, you can either close out the patient's chart here, or you can hit this ED launch point to bring you back.
Adrian, fire away. What was your question?
I'm seeing that there's so many different ways to get to the same place. Is it easiest to just work from the tracker and click on the patient and just like what you were kind of alluding to, Rafi, like at least initially, so you don't get lost in so many layers of stuff?
Yes. It's probably easier. The thing is, you only have access to certain things before you start needing to go into the patient's chart. And once we go to the patient's chart, because you need to document, and your documentation is going to be in the patient's chart. So you can do a lot of stuff from the tracker, but you can't do everything. Eventually, you're going to have to open the patient's chart. If you want to read their previous notes, if you want to do documentation, if you want to, all this is going to end up, if you want to discharge them, if you want to admit them, it's all going to be in the patient's chart.
But the flow of the ordering and the reassessing and stuff is most of that's going to come from just the tracker. If you want to start simple.
You can drive 80% of your work through the tracker. Absolutely.
Okay.
So just a couple things to note. So we still have the critical value here, but this bar below was previously green because all of the results were back. But now you can see that the bar is gray and it's not complete. And that's because we've ordered that CBC to be drawn at 12 o'clock. You can see that. Another thing that happened when we signed up for the patient, a couple statuses changed automatically. So now the eval in progress status has changed. And then we got this note here, this white note saying that you haven't started your documentation.
By the way, how do I change it from eval in progress, or does it continue? Like once I've evaluated them and now they're getting their treatment, what do I do?
So some of the statuses can change based on, like this status changed, everything's complete because all the tasks were completed, all the orders were completed, medications were given, etc. This one here, status changed because there's a discharge order on the patient. This is changed because patient is admitted. You can also put in here if I mean, you could say patient waiting for DI if you wanted to, but you would also see that here, right? Because there's DI ordered and it hasn't been completed. So it's.
So this stays eval in progress until it comes up for reassessment, right?
That's right.
Okay, fair enough. Hey, you know what? Less noise because we had way too many statuses. I agree. Okay. Is there any more questions about the tracker before we dive into our patient? Charlie, your hand is up. Fire away.
Okay, kind of a dumb question, but in terms of the labs or whatnot, say you order a blood culture, okay? It's not going to turn green. It'll turn green, right? Even if the blood culture is not there, right? I mean, is it like the old tracker where it turns pink, even if the blood cultures are pending, kind of thing? Like,
so
you know,
it depends
just
if it considers labs as micro as labs. I don't think micro is labs, correct, Rachel?
Oh, okay. So micro is not in that. Okay.
No, micro will fall into here. It won't turn green because the cultures won't be completed by the time the patient leaves. So you'll have to be.
That's not a good thing.
Yeah, because then you're gonna have to reassess all the labs. Because so many blood cultures get sent out, so it's like you got to check the labs. It won't be green for half the patients that you're gonna see. Urine cultures, blood cultures.
Sorry,
any
guys.
labs,
Kyle wants to say something.
Labs that take like 2 days to come back.
Just 1 second, Charlie. Kyle wants to answer the question.
Yeah, I'm gonna check the build. I believe we might have micro excluded from here, so it won't play a factor in that progress bar.
And that's important, Kyle, because then we'll still be looking at this, waiting for it to go green so we can start actioning the patient, and it won't.
Right.
James, you had your hand up for a second. Do you still have a question?
Yeah, I was going to say I thought that was kind of the way the system is right now, anyway. So it's not like it's something new. I mean, it's not ideal, but it's kind of what we already did with that.
Okay. Beautiful. Okay, Rachel, you're back in charge. Take away the patient.
Yeah, so like we were saying, you can get into the patient's chart. Typically, you're going to do it off of Launch Point. There's either you, again, click right here underneath the patient's name. You can open the chart this way. You can go to your orders this way. There's also a right click. So if I just right click here, it opens up this context menu and we can go to your quick orders. We can go straight to your documentation. We can go straight to your results review. You can attach that pre-arrival if you feel the need to, or the nurse can do that. You can change the event. So I'm not sure if you want to go to your.
Okay.
Go ahead.
James, go ahead. Fire away.
With the pre-arrival, Rachel, is there like how do the people at triage know that there's any pre-arrival information? Like I know I put it in there, but usually they give you a name, half the time it's spelled wrong. They don't have the age. Like I just wondered if there's some way that we make that easier, or do the nurses always check there, or does the patient have to just say, oh, they called ahead? Or
They're going to show up on launch point as we don't have one in here right now, but they will show up on launch point as a pre-arrival. The status will say pre-arrival, and then the nurse can right click and attach, and then they're still going to have to register that patient. So we'll still be able to capture all the correct information.
So preferably you would at least tell the, like if I'm talking to the family doc, just say to them, make sure you tell the patient to say you called ahead, so that the nurse knows to look for a pre-arrival and try and match it, even if it's not
James,
quite accurate.
I think you can add it as well. I'm pretty sure docs can attach it. Do you know where? I don't know where, but I've seen it before.
Yeah, you can attach a pre-arrival, but like the doctor is not going to really know when the patient comes to the window, right? So you're right.
Yeah, but like I can attach it after the fact, right? Like if I see the patients, there's my notes. Where was it? I can't remember.
Attach the pre-arrival here.
Oh, there you go. Attach the pre-arrival.
Yeah.
I know I've seen it somewhere.
Most likely, because you're going to have that status in launch point, then there's this C that'll say it's a pre-arrival. And so once the patient swipes in, they'll say, you know, doctor sent me, okay, that's probably going to trigger the nurse to go ahead and look for any pre-arrivals, even if the information is a little bit off. And that pre-arrival, think of it just as like a sticky note. It doesn't live within the system until you attach it to a registered patient.
Beautiful. So this is the tracker. We said you do most of your work within the tracker, but you're going to have to open the patient's chart at some point to do some work. So what we're going to do is we're going to open the patient's chart and let's orient ourselves to the patient.
So click on the patient's name to go right into the patient's chart.
So yeah, Rachael, do you mind just going back and let us know which patient you're working with? And it just, the slow motions help for people to kind of identify where to click.
So we're doing Roadshow 2, this patient here, and I'm going to click right on the patient's name.
Now, again, I'm going to give you a tour of this, and then I'm going to do a couple of things. So remember when we said the tracker or launch point works top to bottom, the hierarchy in the patient's chart works left to right. At the top, under your buttons, there's a blue ribbon, which are the patient identifiers. And then you get to your patient's chart. So here's what I'm going to do. I am also logged in, and I assign myself as well to the patient. And I am going to do a little bit of document A60. Where's A60? No, it wasn't A60. It was A19, right?
A19, yep, the location.
A19. So what I'm going to do is I'm going to share my screen for a second. And Rachael is still signed in and working on her computer, but now we're both signed in. So now you're going to see my screen. Can you see my screen?
Yeah, we can.
Perfect. So if you take a look, this is my tracker. I'm also signed up here as Rafi RF. If I click on that, it will show me. What did I do here? I double clicked on something and I messed it up. Okay, here we go.
The wrong patient.
A19. Here we go. Oh, it's now crashing. It's going to take a minute. Why did my system crash? Of course it did. Okay. Rachael and I are both signed into this patient. Okay. So I'm going to open the patient's chart. Now, if you remember, Rachael had a blue menu to start with. Mine is still here. This is the main menu. I'm going to pin it by clicking this little pin at the top. Every patient's chart has this top level menus. We have the ED provider view, which is this one. But we can also have just the results view for this patient. These are all the results for this patient that we were talking about. This is the orders. Okay, and these are some orders here that are done for the patient, but there's nothing to sign, right? There should be nothing to sign. Everything is done. Or do I? Yeah, there's nothing for me to sign anyway. Okay. Do you remember this color-coded view? I'm going to collapse all of them to do that. So this is another place where you will do a lot of your orders. And this is called quick orders. You can get here, or it's collapse all. You can get here from within the patient's chart, or I'm going to go back to ED launch point. If you right click on the patient and say quick orders, it'll also take you here. In here, what we have done is we've picked up probably the most common 200 or 300 orders that we use in the emergency department. We have categorized them for you here by category, and you can go deep into them. Like if you want to start with, let's say, medical imaging, you can have X-ray, ultrasound, and CT, and if you open your CT, these are your most common CTs. If you want to do medications, and I want to see respiratory medications or IV antibiotics, and these are my most common IV antibiotics. This also includes your IV fluids. More importantly, it also includes your order sets. And I'm going to talk about order sets later, but these are your standard order sets for the emergency department. Most importantly, it has the new order entry. You can search for any order from here in the system and order it on your patients. I tried one yesterday. I tried VMA, vinyl-mandelic acid, 24-hour vinyl-mandelic acid, and it's there. How many times have you ordered that in your life, right? But it's there and I can order it. Again, this is just a way of ordering them. Eventually, they'll end up in the same orders box where I'm working. So if I was to order on this guy VMA, I don't know how much it needs from me, vinyl-mandelic acid order, and I go here, modify my order, and it will be in the orders for me to sign. Now, when you get here, my advice is always start working with missing required details. Every order that has a blue X on it needs information from you. And you can do it by clicking on them one at a time. However, if you have 20 of those in an order set, all you have to do is keep clicking this and it'll take you to the next one that's missing. So it needs 24-hour urine, and that's the only thing that's missing. Sign, and I'm done. I've just ordered VMA on this patient. I don't know why, but I did. Oh, it's still thinking, sorry. Why is it so slow today?
I would like to guarantee that this will not happen live, right, Ben?
Ben guarantees it will not happen live.
There you go. Thank you.
Okay, so documentation is all your documentation about the patient that's present, diagnosis and problem history, medication list, etc., etc. MARS summary, this is the MARS and whatever medications have been given to the patient. However, most of the time we will work in ED provider view, and this is the patient's ED chart. This is the equivalent to the paper chart that we held in our hands and everything that's attached to it. And that is why I have hidden this, because most of the time I won't need it. If I need to go somewhere, I'll just go to the menu and then I can jump to it. So for me, I've hidden it. I don't need it all the time. Your ED chart, let me move these back just so I can show you how I got there. The patient's chart is one long document that you scroll through. It has tabs, just like a patient's chart, orders, HPI, physical exam, reassessments, triage review. There are microbiology labs. There's something critical in labs, right? Labs, oh, I have to wait. Sorry. Ben assures us this is not going to happen live. Okay, pathology, etc. What I have done, this is the long view. Before, what I did is I moved my documentation to a side pane and cut this in half. And I moved it the way I document. So the first thing I think I want to document is history of present illness. Then I'm going to document the review of systems. And then I'm going to document a physical exam. Then I'm going to document my reassessments. And then I'm going to document my procedures. And then I'm going to document my impression and plan. So what that does is, as I am scrolling through the patient's chart and I am working, I can document on the side. Now, I'm going to give you a side note. I told you that everything here works left to right. Asterisk footnote. But you notice at the top, even when I'm in the ED chart, there are different types. There are tabs here I can get to. ED workflow is the most things, but I can see all the assessments on the patient here. I can do their discharge here. I can do their admission here. I can look at their chronological view of everything that we've done on them here. And I can look at their demographics here. Okay? So now what I'm going to do is I'm going to start dictating. So I walked into this patient. I'm taking a history. Yes, James, fire away.
Sorry, I just missed on the clicking as to how did you split this screen in the first place?
Oh,
'Cause I'm
all I
guessing
did
there's
was,
one-
okay, I'm going to bring them back for you. I'm going to show you. So
I
the
saw you move them over. I
documentation
just didn't know how
part,
you split it in the first place.
yeah, the documentation part, which starts with, where is history of present illness, has a little arrow at the top. You see that?
Yes.
Which moves it to the side pane, and you move them in the sequence you want. So if you want to move your review of systems first and then move your HPI, you can.
Okay, so as soon as you click on that, it creates the pane. You don't have to create it
Exactly.
separately.
So I'm going to redo that. So history of present illness, review of systems, assessments. Okay. And there we go. So anywhere I go, I can type. So I can say fever for 3 days. However, this is really inefficient. So what I have done is I've launched my little dragon here, my dragon friend, and all I can do is click on this. Or if you have a long keyboard, if you hit the plus sign on the number pad, it'll turn it on for you. And now it has turned green. Oh, wait a minute. I did not put it there. Okay, so let me delete that. So wherever I am here, I am. Patient has had cough for 3 days, period. He has some mild shortness of breath, period. There's chills and night sweats, period. There is no sputum, period. There's no chest pain or abdominal pain, period. There is no dysuria, period. Now, did you notice this little anchor here that turned on? This anchors the cursor here. So no matter where I am in the chart, so even as I'm talking, I can scroll up and down, and it'll still dictate up in the same spot. See, I can scroll up and down and still dictate at the same spot. So the beauty is you can keep dictating and moving up and down to the chart, collecting information. I'm going to move to the review of systems. The patient has no genitourinary symptoms, period. He has no GI symptoms, period. There's no rashes, period. The remainder of the review of systems is negative, period. Now I'm going to move to physical exam. The patient is in moderate respiratory distress, period. He is uncomfortable, period. There's definite sweating, period. Mucous membranes are dry, period. Skin examination is normal, period. Head and neck examination is normal, period. Chest examination showed bilateral mild and expiratory wheezes, period. Heart and back examination were negative, period. Abdominal examination showed no tenderness or peritoneal signs, period. There was no sign of joint inflammation, period. Limb examination was negative, period. And that's my documentation. So I go back and forth, and I'm reassessing the patient, and I am going to say, the patient felt better on treatment, period. CT scan of the abdomen was ordered, period. Now, what I can do as well is, new paragraph, 2 p.m. CT scan shows a collection of pus in the pelvis, period. The plan is to refer the patient to gynecology for further management, period. Now, I'm going to go to procedures. What did I do for this patient? Bedside ultrasound showed no free fluid in the abdomen, period. The patient was fluid resuscitated and received empiric antibiotics, period. His temperature was treated, period. He received antiemetics, period. He responded well to treatment, period. He continued to have cough, period. He didn't like biotics.
It also said there was no sign of joint dislocation for you.
Empiric antibiotics. See, my mic is listening to you, James. Anyway, but you get the idea, right? Impression and plan. I have discussed the case with Dr. McMillan, period. She was kind enough to come and see the patient and assume care, period. Now,
be careful what you say to your children while your dragon is on, just as a personal note.
Oh, yes. So what happened now is this dictation is in the chart. This is my dictation. Rachel can do the same on her own. We don't have to do this. Each of us has this. And then what we're going to do at the end is we're going to pull all this and turn it into a chart and an ED note. Okay? So I'm going to stop here. I'm going to hand over. Oh, wait a minute. There were a few questions. Pam, you go first.
Two questions. One is, how do we look at past transcriptions? And two,
Right.
with this documentation, would you have the opportunity to just pre-code some of your like review systems? Like, can I? Okay, yeah.
Okay. So first question. So your patient's documentations are clinical documents. So the only clinical document the patient has is a triage. Now, past documentation, Rachel, does it show up here or does it show up in the blue menu under documentations?
Hey, Rafi, where you are, without the blue menu, in the top right, there's filters. So right now you're on all visits. And then you also have those filters.
Okay.
And you have more of those. But you could also go in the dark blue menu, documentation.
Perfect. So these are the two places where you see it. Okay, let me click that.
Yeah, that patient doesn't have any previous documentation, but I do have a patient who does have quite a bit of previous documentation on them.
Keep a mental note of that so you can show us when we go back to you.
Yeah.
Great. So I'm going to go to ED provider view. Okay. What was the second question you said? Oh, yeah, of course. So for example, my Dragon. So there are texts in the system itself. I honestly don't like them, but I have things in my Dragon. They're called manage auto texts. So I have multiple things that I have done that I can use, right? So for example, this is my standard one for Form 1s. All I have to do is go anywhere I want to enter it, turn on my mic, Rafi's Form 1. There you go, and it's in. I'm going to delete that. But that is my Form 1. So I have several, and I'm probably going to be using more of those as time goes by. And I'll just put them in my Dragon. All I have to do is pause for about a second, give the name of the auto text, pause for a second. It'll enter it for me. Who's next? Mel is next. Oh, sorry, it's not Mel, it's Trelly. Sorry, MS and Melanie and Michelle.
Sorry. Yeah, sorry. So is Dragon used the same way that we have now from our phone, or?
So you can use it anywhere. So
like
you are here.
Straight for the computer, like what I'm doing now, talking to you. I just press it and it can go straight from my laptop from my mic.
So exactly. So watch what's happening here. So I'm going to pick. You can pick different microphones. So for now, I can pick my big. Oh, you can't see it here. I have my big blue giant microphone hanging from the ceiling, and that's the one I'm using. But I have two microphones on each of my screens that I can use. But I can also go to my phone. So let me change that to my phone and show you how it works. So Nuance Power Mic. Now it changed to my phone. Now I'm going to take my phone. I'm going to open my mic. Oh, I have to. What's new? No, I don't want that. Oh, is that trying to sign in? So this is my microphone.
Okay, so it works like the old system.
Exactly. So what I'm going to do now, I'm going to dictate using that. And I'm going to use something else. What else do I have? Rafi's anesthesia. And there you go. That's my anesthesia note. And I dictate it through my phone. So you can choose your phone. You can choose any mic that's attached to your computer, whether it's a dictation mic, whether it's your computer's mic. I find if you're working from a MacBook, the mic is very, very good. It's good at voice isolation. Unless it's really busy around you, you don't need a handheld mic, but you can definitely go to this.
Okay. And second question is, I know you can go back to the triage. For example, a patient obviously can't give a history. They have dementia. They're coming from a nursing home, and you basically use the nurse's triage note for most of it.
So here it is.
Triage. Go back there and do a copy paste, right?
So you should be able to copy anything you want. Although I will tell you, I would highly discourage you from copying the triage note. It won't look good on a complaint or a lawsuit. Okay. So read it and rephrase it. That would be my advice. But of course, you can copy. Control C, Control paste, and here it is. because all your computer commands still work. So I just use Control C, Control V. So Trelly, I'm guessing you're done, or do you have another question?
No, I'm done.
Great. I'll move on to Sarah.
This kind of follow up to what Trelly just spoke about, but in terms of bringing.
Oops, sorry, I muted you.
That's
I
okay.
muted you by mistake. I'm so sorry.
In terms of bringing in things like vital signs, labs, imaging results into your note, is there a way of?
So they will collect that. Okay, let me take it to the next step. Okay, so let me start an ED note.
Hey, Rafi.
Yes, sir.
Actually, before you start the ED note, can you close out of this?
Okay, let me cancel.
So everything, I'll just say everything pulls into the note except labs. Labs, you can discard changes here.
Yeah.
Lab, you would need to tag the specific ones you'd want to pull in, or else they would pull in everything, right? So Rafi, you go to the labs component on the left.
So let me close that. And labs.
And if you click one of those, like the critical one, you can click, maybe if it loads, should be a little bit longer than that.
No, it was not here.
Highlight that 29. Let's see if we can tag it from there.
On here?
Yeah. What happens if you highlight it? Nothing. This window should pop up wider, and there's a tag button at the top. So maybe click on another lab. There we go.
Here it is at the top. Okay.
Yeah.
So why did it not show up when I did this?
I'm not sure.
Oh, here it is at the top. It showed up this time.
Yeah. Okay. Click that,
tag it.
and then now create your note.
Can I tag general chemistry? No.
Yeah, you can tag any labs and anything within a clinical document.
Yeah, but I can't tag all of them at the same time, can I? Like I can't tag all of them. Oh, I can tag all the labs.
Yeah, that's did there. You might be able to shift click, but I actually haven't tested that before.
Shift click? No. Right click? No. We tried. Change filter. Anyway, so we've tagged this. I'm going to tag the EGFR as well.
So you need to tag every single lab value?
Labs
it looks like
it. That you need, that whatever you want to pull into your note for labs, you would have to tag.
You can control click all of them, and then they should pop up. Go back to your labs.
Okay.
Yep. And then click in the value, so 140, and control, and click, 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 click. Oh, mine highlighted all blue. Keep going. And you'll see that they're under the tag, under labs, they're adding up.
Rachel, you're amazing.
That's okay, you tech boys.
I know, tag 9.
Okay, go back.
Perfect, I tagged them all. Ha-ha, beautiful. Okay, so now what I'm going to do is I'm going to create my physician note. Usually you do that at the very end, but I'm going to create it right now. So when I do that, it pulled the labs, it pulled my primary, I don't have a diagnosis yet. So I need to add a diagnosis. It pulled my history physical, and we intentionally put the diagnosis and disposition plan at the top for the family doc so they can see that. It pulled on the side history, social history, the labs you've just tagged, and then you can submit and sign it. Question, Kyle, how do so I'm guessing these will have a default that they will go to the family doc, but how can I add people to my note for the distribution?
Yeah, so when you hit sign and submit, you're going to get another pop-up. And this is where you would send it. So that provider name search there.
Here. Okay. So let's look at Santamond. Let's see if he's there. No, maybe there's a dot in Santamond. No. How about Campan? Is Campan there? Oh, there she is.
Yeah.
I'm going to send it to Azabi because I know Azabi is there. There you go. Beautiful. So review CC or sign. I just want them to review and CC, right? I just want to CC it to them.
Right.
Perfect.
And then you can favorite them as well there on the stars on the
left
side.
You can add your favorites. Yeah. Gotcha. Here, I'm going to send everything to Tariq Azabi from now on. Okay. Okay.
But will the family doctor automatically generate though the same way it does right now?
I'm thinking family doc should be automatic, right?
Yes.
Okay, great. I'm going to cancel. I'm not going to do this yet. I'm going to cancel that just because if we need to do something with it later.
We have a
discard.
question.
Yes, ma'am.
Dr. Crow.
Oh, Adrian,
Oh,
yeah.
yeah.
Adrian,
Is there
it here
is there
or-
a way to is there a way to dictate without using Dragon, just to avoid a whole extra set of training? Can you just dictate from the mic, or in those boxes, or should we
So
be?
Dragon is your vehicle to dictate. So Dragon, the system treats Dragon as a keyboard. So if you want your keyboard to be voice recognition, it is Dragon. That's the because as far as the system is concerned, it doesn't know Dragon. It thinks it's just another keyboard the system has.
So get Dragon trained as well.
So you don't really need Dragon training per se, because the old way we did Dragon was different. It's
Right.
because dictation was not part of the chart. So most of Dragon dictation training was about using the dictation as software. Now you don't. But to be able to use those things here, yeah, you need to know what these are if you want to customize them. It'll work out of the box. Like if you customize nothing and just turn it on, you start talking, it'll type.
Okay.
You don't have to train it anymore. Like if people did Dragon 7, 8, 10 years ago, you had to spend the hours training it. You don't. It trains as you speak. It learns. You just choose your specialty when you first sign in.
And your auto texts, can you do that embedded within Dragon within this
Yes.
system, or do you have? Okay.
So you have to set up your own, right? So
Right.
manage auto text. I can add as many auto text as I want, right?
But you do it with just like we're looking at it. You don't have to have a separate Dragon interface or training or
That's
anything.
it.
You do
That's
right-
it's all through
yeah.
this. So I'm going to hit one now, and I can call what Adrian's note.
So when we do our favorites fair, we could probably set some of this stuff up or just try it out or whatever. Or would it not be? Or it's just
I am
only
not
after
sure
launch?
if they're going to be able to help us with. Ben might be able to answer. Is Dragon included in the favorites fair? Or Kyle, do you know?
I don't know, but Idris, do you know if it's included in the favorites fair?
Yeah, I mean, let's confirm. We have a meeting today. We can confirm for sure.
It seems
Okay.
like one of the main advantages would be the auto text that you can set up.
Adrian, I've been using Dragon
Yeah,
a long
I mean, it's
time,
something we
but I'm
can-
not Rafi. So as a non-Rafi person, it literally took me 2 seconds. But finally yesterday, after dictating everything out for like years now, I was like, wait a minute, I'm gonna make some auto text, and it took like 2 seconds. It's like I didn't need special training, and that was like initially when I set up my ED note and all those things, I set that up with I think it might have been Taro like years back now who did it. But anyway, the stuff now to put those auto texts was actually like crazy easy, simple.
So I just create a note. I called it Adrian's note. I just hit plus. I populated its name. I put some text in it, and I saved it. So now if I go here, and if I say Adrian's note, there you go. This is Adrian's note. No, nothing more or less. That's it. That's all it took to create.
Okay,
auto-
perfect. I just didn't know if I should be
straightforward.
signing up for Dragon training. I was avoiding it because
No.
of how cumbersome with the
I
old
know you've
system.
been avoiding it, Adrian. I know.
Yeah. Well, it didn't make sense to learn how to do it when you don't need to know how to do it. So
It's the thing is, do you notice how my speech changes and my tempo changes when I'm dictating? That's actually the part that takes a while getting used to, is when you speak to Dragon, you have to know how it understands you. And that's what takes a while. It's not really the tech. The tech is very easy. Okay, so that's done. Okay, so I deleted that. Okay, was there somebody else with a question, or can I hand it back to Rachel? Okay, so all Rachel needs to do, I'm still logged in. Rachel needs to share her screen and she'll take over. She'll show us what she's doing.
So I guess maybe we should just finish off with this patient first. You're going to want to add a diagnosis. Again, there's a couple different ways to do that. You can go here to the problems list. Any chronic issue is going to populate here. If there's no chronic problems listed, there'll be a tab that says no chronic problem, and that needs to be checked off. And then for this one, you can add your diagnosis. I'll just show you one other way to do that. Is you can actually click right in here. So you can see these patients already have a diagnosis added to them because the DX, but our patient here Headache was the CETUS complaint. Click on it and you can add your diagnosis right here. You can also see now that because Rafi started the documentation, it's in progress. Go ahead, Kelly.
Where did the chronic problems come from? Is that from like past medical history or?
Yep.
Okay. It pulls it in for us.
Yeah.
So this is a very important concept that's probably new to us. Those of us who've done family medicine maybe remember the problem chart on the first page of the patient's chart in family medicine. The system has a problem chart and it carries with the patient. And every time we touch the patient, whether it's us or internal medicine or surgery, we can add acute problems, modify chronic problems, or remove them. And the idea is with time, you will have a snapshot once you look at the patient's problem list of what their past medical history is, what their active problems are, or what their inactive problems are. It's a change of practice for all of us across the organization. Before I go to Adrian, Kaylee, your hand is still up. Is that legacy or do you still have a question? Oh, yeah, perfect. Adrian, fire away.
Can you free text the diagnosis and also can you have more than one?
Yes, you can have more than one. Free text, no, you are committed to ICD. Is it 10 or 11?
10.
10.
10. But you will find if you've ever worked with ICD 11, 10, you can think of something and it's going to be there. And there's going to be 10 version of it.
So you can see that I added another diagnosis and then you can change the priority depending on what you want first. You can also resolve chronic problems. You can resolve them all.
James, fire away.
So but if somebody comes in and it's like abdominal pain and I don't have a diagnosis, is that under like, does ICD have just a non-specific
I'm
too?
sure it does.
Okay, I thought it did, but I wasn't sure because I just haven't used them.
I want to talk a bit about order sets. Whenever you're done with where you need to show them, I want to take them back and do some order sets because we only have 12 minutes. Kaylee, fire away.
Sorry. So does that mean like these people are going to have every time they come in, if they have like an abdo pain NYD, it's going to be showing up in their past medical history every single time?
If you've designated as a chronic problem, yes, right?
But if it was this visit, like we discharge them with that, how does that re-show up in their subsequent charts?
If you tick it as chronic as well.
Oh, okay.
So also there's a drop down at the bottom of this problem list, all previous this visit problems. So those are all previous diagnosis, not chronic. And then in the patient summary on launch point, there's a previous 5 ED visits. We'll show the diagnosis as well there.
You know what, Rachel, Kyle, we're becoming such an amazing team. I love this. We work as one organism now.
That's right.
Too many meetings. Do you want to just quickly show them results callback?
Okay. Can I do orders first and do results callback at the very end? Just because the results callback, it's still not completely mature and it's not critical, mission critical. Ahmed Farag, go ahead, Ahmed. Ahmed, you need to unmute yourself. Here, let me unmute you. Oh, I can't unmute you.
Sorry, Rap. Quick question. Like, like what we are doing now in Emerge, like writing things in papers, and I feel like we're gonna have like big move from papers to paperless. So my concern is like, like sometimes we see people write orders, throw the chart, finish later on the day. I was thinking like if we're gonna start the day with like I need just to finish every single patient before I go to the second patient dictation, like dictating.
No, you don't need to. You don't need to. So you could quickly sign up, throw in a couple of orders, move on. You can even discharge the patient and do your note tomorrow. If you're finishing at 3 o'clock in the morning and you're tired,
choice like we can do that later on.
Yes.
Like the chart was still under my like name and.
Yes, you'll find the patient is under the checkout, and you can. Here is what I'm going to warn you of. By the way, first I want to just tell everybody. I don't know if you've noticed in the recording today, I called Ahmed Habibi. So it's now embedded in the recording of this session. Second, yes, you can. The one thing though I want to tell everyone, unless you have created your note and you have signed it, you have not completed your charting, you have no chart in this patient's record. If you come back later and there's a complaint or there's a lawsuit or there is something, if you have not created your note, you have nothing to live off. There is no paper trail. So it is extremely, extremely vital that from day one, you might not need to do it now, but you have to make sure that you create your note and you sign it for every patient. And it has to be signed, because if you don't sign it, it doesn't close. So even though your dictation, the stuff I put in the fields there, are still in the chart, but they're not locked. So they lose credibility. So it's very, very important that you do your notes, because there is no paper. Kyle, I think you went off mute. Fire away.
I was just going to add here in the checkout tab, that's why we have the My Unsigned Notes filter at the top next to My Patients. Yep. So we can filter by all of our unsigned notes. So when you're at home after your shift or whenever you're kind of doing your reconciliation, you can go into the checkout tab and make sure you have green check marks for the notes.
Yep. It is extremely important. There's no paper trail, right? So in one way it's easier, in one way it's very important, because now you're tied to your computer, you're tied to the software. So all you have to do is sign up, throw in orders, move on. The computer will remember it's your patient. But sign up, sign up, sign up. Trelly, fire away.
Did you say that there's still stickers? So say someone shows up at triage, you can grab a sticker. You need your stickers for billing.
So we're going to get to billing in a second. Yeah, go ahead.
For your billing.
Yes, you can use stickers. I'll be honest with you. It doesn't make sense to use stickers, because all you have to do is click sign up, and now the system remembers for you. And then you can come back at any time. You can't lose the sticker. You can't miss a sticker. Just click sign up. That's the only thing that you have to embed, is when you're going to have a conversation about any patient, first sign up.
Yeah, but sometimes say you sign off because of you're sending the patient to somebody else.
It'll still show up when they're discharged and checkout.
Okay, and how do you send all the information to your billing person?
Okay.
Without all that information, like just
so there's two things. So first, I want to show you something. Do you see that little P in a green hexagon? Is it a hexagon? It is a hexagon. So this is for out of province patients. So the paper colors, 3 copies, are going to disappear. You have to order your billing as an order, so finance knows it's you. So let Rachel bill that patient. Can you hit that P?
Yeah, I'm going to go in.
Oh, you have to go in the chart. Okay, doesn't matter. Anywhere where you can put in an order, right?
So you can quickly see here, you've got your quick discharge patient or your ED billing.
But you can search for it anyway. So she's going to be the first physician, and that's all she's going to do. And she's going to sign it. Now she's attached. What I'm going to do, watch what I'm going to do. I am going to share now. Can you see my screen?
Mm-hmm.
Now, what I'm going to do, I am the second physician because I helped Rachel, right? So in my orders, what I'm going to do, I'm going to find ED billing in another way. I'm just going to go say ED billing. This is for out of province, right? I'm going to click that. Now, am I the initial? I am not the initial. And I want 4 units of $50 signed. So now finance knows Rachel was the first doc. They'll pay her. And then they'll pay me the extra unit that I built. So that is for out of province. For OHIP patients, which are 95, 98% of our patients, you're gonna produce a report. It is not ready yet. There's a couple of reports that will be there. You're going to be able to produce a report that has any patient you documented on, say in the past 24 hours. Anybody I've started the documentation on, I can print a list of those. It'll have all the demographics so you can bill. So for example, Nadi does billing for a lot of people. If you remember Rick Mann, Rick works in Trillium. So Trillium, Rick, when he finishes his shift, he prints a report, does his billings, and fax it to Nadi, and Nadi does his billings. So you're going to do the same thing. Instead of the yellows, you're going to have a report. We have also created a report, which is very important, where you can pick up through any time period any patients you ordered something on. I'm hoping that we're all going to sign in and sign off, but still, if you've entered an order on a patient in a time period, you'll be able to generate a report from that. So that will include, for example, if you get called for a code blue and you go up on the floor and give some orders for a code blue that you did upstairs, you come down, you'll be able to pull that data into your report, that patient to your report and bill them. Does that answer your question, Charlie?
Yes, except how do you pull out the reports? How do you pull it out?
They're not ready yet. We will show you. They're going to be ready next week. So I can't show you yet.
Oh,
So
there is
Rafi,
something. Sorry, go ahead.
Sorry, so you do a code blue, you got to find that, sign up for that patient, and then sign off for them.
So remember, you don't have to sign up for a patient to write an order. It's just when you access their chart, you have to tell them why.
You can only really bill for when you write an order then.
So it's a way of finding the patient, right? Look, because all you need to do is to generate the report that has the patient so you can bill it. So if you order an epi, it's under your name. If you went upstairs and ordered an epi, you're done, right? That patient will show up on your report.
Okay.
But you can enter orders on any patient. It's just that if they are not yours, when you open the chart, it'll tell you why are you opening the chart.
And in that top right corner, the white box, you can search for any patient at any organization.
Right here. No, that's search the chart.
Up top, right up top.
Right here. Okay.
Yep.
Okay. So why did I come here? Oh, I wanted to show you. Oh, I entered another billing. Okay, and we talked about that. So that was the billing question. Was there another question, Rachel, we need to touch on? Okay. Now, guys, we have 3 minutes left. Even if Rachel and Kyle go, I'm happy to stay if you want me to. If you have any questions, I'm happy to do that. I just want to talk about a few things. I want to talk about ED discharge. So this is the ED discharge. We need a diagnosis. There's one document. Didn't you enter a diagnosis on this patient or no? Do I have to refresh?
I did enter a diagnosis. Yeah, refresh.
Okay, yeah, I just refreshed it in the patients here, right? So enter a diagnosis. I'm going to add another diagnosis. Adrian, think of the most obscure diagnosis you can think of. Let's see, crisis. And there you go. There's all kinds of crisis.
Abdominal crisis.
Yeah. What is situational crisis? What's the ICD-4 for it? Situational stress, situational phobia. There you go. Situational depression.
Yeah.
Situational disturbance, transient. You can think of it, and ICD-10 has it.
As long as it has all the NYDs, because I love keeping my diagnosis
oh yes,
vague for when they're
let's
vague.
see, NYD, no, not yet. Let's see what's, there you go. All kinds of not yets.
Not yet
Mental
walking.
disorder, not yet deliver. There is not otherwise specified.
Oh yeah, there it all is. Yeah.
Yeah, no, I misspelled otherwise.
Emotional
There you go.
upset's my favorite one for PERT. I don't pin psych diagnosis. I just loss of emotional upset. But that could be situational
Emotional. There you
crisis.
go. Emotional upset.
There it is.
Number one, Adrian. You name it, it's there. There you go. Let's add emotional upset. Just for Adrian. Okay. Now, I wanted to talk about order sets, guys. So remember when I told you that no matter what you do with an order, it ends up here. You can order single orders from your ED launch point, which was here. I can do this. I can enter X-ray of the foot and add it. I can order things from the patient's chart. Where is he? Oh, he's up there. I'm cancel. I don't want to change your room number. Okay. You can enter it from the ED provider view, from new order entry. You can choose to order it from quick orders from here. It doesn't matter what you do, you're going to end up in the same spot. However, while we've generally worked in shooting single orders, this doesn't work as well in this environment because there are things you might not think of that are actually orders, like inserting an IV or inserting a Foley, or a lot of everything is, all the tasks are driven by orders. So I am going to highly, highly recommend that you work out of order sets. There's almost 84, 85. There's more coming. These are some of them here. These are not, we're still working on the latest ones. We worked on pediatric seizure, I think, yesterday. But what it does is it gives you a list of orders to work from. And I'm going to guide you through one of those. But before I do that, Ahmed, what do you have?
So sorry, Rafi. Like I was thinking like ahead of time, like how we manage this in the urgent care. Like how I see 60 patients like in the urgent care and I will be able to do all of this like same day.
So here's what happens. It depends on how prepared you are. You're going to lose about 30 or 40% of your efficiency day one. You'll very quickly learn, and that's why we're doing all these support and practice shifts. I have spent tens, if not hundreds of hours in the system. And as you see, there's a lot of things I still don't know how to do. The only way is to keep practicing and working, Ahmed. It takes about, so one of the best deployments was Mackenzie in Richmond Hill. At 3 months, they were seeing more patients than they were when they were on paper. But they had a very good implementation. I think ours is excellent. Our ED team has been amazing. But beyond an excellent implementation, you need all of us to learn and practice as much as we can in the first few weeks. Because at the end, you will actually be faster. You will see more patients put them faster once you master the system. Because at the end, 85% of what we do is repetitive. So once you master that, it is so much faster. Just think of a CT. There's no rec, there's no sticker, there's no fax, there's no OE, there's nothing. It is amazing. It flows right from your tracker straight to the eye.
Yeah,
So
I agree. I agree, and I'm gonna like I totally agree with you. And mostly everything was practice will be easy on the go. But I mean, like, do we have any plan? Like, because you know, the last patient if registered like or triage, like 1 minute before 8 p.m. I have to see him. So like to see 60 patient if you work solo in big day and one of the
Pam wants to answer, so I'm gonna let Pam answer.
Yeah, I can speak to that. And yes, there is a plan. So you know, remember what just like when we opened those extra shifts in the UCCs, recognizing that the UCCs don't stay open for 24 hours. So you'll have to see all the patients and close. We're going to open those extra shifts and having physicians come in between 1 and 4 until the end of the shift to work. So for the first month, we have enough funding to do that, both UCCs and focusing on those, like especially obviously the physicians who work solo. Those will be where they will have the extra shift coming in. It all depends on the physicians to sign up for those extra shifts. So that's the strategy, right? Like we'll open them, there is funding, but we need people to actually sign up. One, it benefits both physicians, and two, it also benefits the fact that you're practicing and I have another physician there on board who's working alongside with you. So if everyone is on board with it, it will work just fine, and we'll get enough people signing up and for us to all work together. So that's the plan, and you'll get that communication on Thursday, and the shifts will be open on Friday.
All right, sounds good.
Go ahead. So go ahead, Ahmed. And Pam brings up a very important point. We can only do this if we all live together. That's the only way we can do this. And in 6 months, we'll look back, and none of us will want to go back to a paper chart. Believe me. Okay, so I'm going to pick up an order set. Which one is complex? Rachel, what do you think? Let's do, what do we have? Do we have pediatric sepsis here? We don't, right?
No, I don't think that's in yet.
Okay, let's do COPD. Let's pick up COPD. Okay, or congestive heart. I'm going to pick up congestive heart failure on this patient. Now, once I clicked it, it went to my box. I'm going to click on my box. Here, you can click sign. I have learned not to click sign, at least not now, because there's always things I need to change. So I always click modify details. Now, modify details. And this is going to start looking familiar. Remember this? Now it's full of things in the abdominal, in these congestive heart failure. Now, these are, some of them are pre-selected, some of them are not pre-selected. We have built those to match most of the work that we do. So, do I need MPO? Do I need cardiac diet? Let me add a cardiac diet. Activity has been tolerated as fine. Vital signs now, and as needed, vital signs every 4 hours. Weight now. This is another thing. Without a weight and a height, you cannot move. You cannot order anything. You cannot discharge the patient. You cannot give meds. It just locks you in. So you have to order a weight and height if it's not done. Oxygen. Let me ambulate with pulse oximetry. I'm going to put a catheter. I need a peripheral
So
IV.
is there no way to override that? Because we don't know the weight and the height of 90% of the people in the emerge. We're just guessing.
So triage. Sorry, Rachel, go ahead. You fire away.
Yep. It's going to be a teaching point that we need to absolutely capture the weight at triage as much as possible. And then there's also a way to put in estimated weight and height. But as much as possible, it's going to be new for us. No one likes it except for pharmacy.
It just seems like such an arbitrary parameter to hold everyone up to, right? Like it's relevant in so few instances, yet every single chart won't be able to reconcile.
I'll be honest with you, Adrian. I am guesstimating if I get stopped. And this is what I try to tell everybody when we talk about mandatory fields. I said, if you ask too much and you ask things that I don't know, you'll get garbage data. But I'm going to guesstimate. I'm in a busy, I'm not walking somebody and weighing them. So how much do you think you weigh? Great. Well, look at that. Yeah.
What's the rationale to have it as a stop point then, if we're just guessing anyway? Why have it?
It's a design issue, and it's an organizational wide initiative. Once it embeds and everybody has a weight and height, life will be better.
But then we won't even know if they're accurate because everyone's just putting in.
Yeah, that's the problem with forcing things. Is you start collecting garbage. Kaylee, your hands up.
Sorry, it was already up because I just spoke.
Okay, so I'm going to keep moving. So I'm going to order lactated ringer maintenance. So there's IV boluses. So, and what you can do, so if I pick lactated ringer here, I can click the arrow here and change it to 500 mils. I have a few options. But if I click on it, I can open the whole thing. So this is, for example, this was the bolus, and you can change any parameter in the bolus. I'm going to take an infusion of sodium chloride because I want to. Now, what I can do is if I click here, it's 30 mils an hour, but I can choose another option if I want to. Nitrites, let me put a dermal patch on them. Let me order metallazone at 2.5. Let me order furosemide IV at 120 milligrams. Now, I want to show you something which is called subphases. So do you see here where it says vasopressor subphase, ED lab extended subphase? Anytime you enable this is system-wide. And because it's embedded here, it'll go and open it for you. And let's say I want to give him norepinephrine 16 mics. Okay, and I'm going to go back to I'm going to return here. And I'm going to consult critical care, for example. Okay, now that I have done this, I'm going to say orders for signature. So this will show you things that are ready for you to sign, and it will show you anything. Was there a CT there I can add? Okay, anyway, because I want to add something else. Can I go back? I can't go back, can I? What about I do this? Yeah, it takes me back.
You can just click the add button too at the top left.
Oh yeah, that's right. I could add. Is it this one? Add an order. And let me order a CT abdo, for example. CT abdo with without. There you go. And done. Okay. And now I'm not going to fill this just because I want to show you this. So I'm going to go here, and if you notice, I have 2, sometimes 3, sometimes 4 things that require information. The best way to walk through them is use this. So it says missing required details 2. I'll click it, it'll take me to the first one. And this guy is waiting for me to start, and I want to start this at 2 mics per minute. Let me go to the next one. And it's going to actually, it's going to ask me for reason for exam. Now, the reason exam for the CT is the actual history, right? So whatever, a 60-year-old male with fever and abdo pain and tenderness. And right lower quadrant, right? And now they're all done. Sign. And they're all gone. What is this? What's that error code? Should I have something to worry about, or is it just
No, it's just an error that's being worked on.
okay. Okay, interactions. Do you want to continue with this? Yes. And done. All of them are signed. So this is order sets. Any questions? Yes, try.
Is there a discontinue button? Like if
Aha.
you discontinue something that was
I'm going to
ordered-
give that to Rachel because she's better than me at this. Rachel, you go ahead and discontinue something from my orders.
Okay, I'm going to go into the patient's chart.
Or
And
you
actually,
just
I
share
don't know
first. I can't see you.
Oh, you can't see. Oh, sorry.
You're seeing me.
You can see here that the status changed because there was a consult order placed. So consults in progress, and then that updated here as well as all the other things that were ordered by Rafi. So if you go into the patient's chart under orders, all the orders live here. You can just right click on anything. You can modify, you can cancel and reorder, cancel, discontinue.
You can convert to a prescription. I like that.
Yeah, I've not seen that one happen, but let's click on it.
Now, I do want to say something. I want us to get into the habit of entering consultations when we decide the patient needs a consult. The consult drives the clerk to order to call the consultant. You can put in a time to call in the consult. So if you enter a consult, you can say, call this guy at 7 o'clock because they're coming in the morning. However, I really want us to get into the habit of writing consult times when we decide we want to consult, because the fact that departments do not respond overnight is not the emergency problem. Like, we're happy to call them in the morning, but I have decided that your consult is necessary at 2. And the fact that you don't take the call until 7 and don't show up until 11, that's a consult response time. Our consult response times look great because we don't document the time when we wanted the consult. Can we modify the consult critical care? Let's see what we can do. Oh, here it is. Can you show me where I can chat? Here, offset details, I think, right? Or comment. I think it's in offset details. Oh, it's already ordered. That's why you can't change it.
You place the order, yeah. So we'll need to order a new one.
Or just modify it. That goes to Trelly's question, right? You can't modify it?
You would have to do something called cancel and reorder. So if you click it, that's because you pressed modify here. Modify would only let you play around with special instructions. You got orders for signatures, so just you gotta just finalize that, put it through, sign, and then do a right click. Oh, you gotta refresh maybe. Yeah, cancel reorder. There you go.
See, you can put all kinds of details. Where was the?
Thanks, Ben.
Where is the time to call? There was a time to call. Is it in the comments, maybe?
Well, we have that on the nurse and the ward clerk task, right?
Okay. I don't know because I haven't seen them.
Do you want me to go log in as a nurse?
It's okay. It's okay. So where do I put it for you if I want you to call at 7 o'clock in the morning? In the comments?
So when you fire this consult, it actually is going to fire a task for me as well as for the clerk, and then we can go and finish that task.
Okay.
If you've contacted the provider, then you really should be telling the nurse or the clerk, hey, I already contacted the provider and we can document.
Because that's what I do. I call 90% of my consults. Trelly, question?
Oh, I guess that was the whole thing about calling. I didn't know if, so this limit, basically, we don't have to tell the clerk, can you call hematology for me? Or anything. We don't have to like have a communication with them at all. It's all through this computer.
You don't have to have a communication with them, but it is ideal. They will have like the tracker open and then their tasks, and they'll be able to see, oh, there's a new phone icon that hasn't been initiated.
Okay, and then they'll call you on your Vocera when it gets
or your extension.
Vocera then, rather than okay.
Okay, yeah. Before I go to Kaylee, so the tasks are all driven by orders, but it's not a replacement to communication, especially when there's a variation, right? Like if I want to call me now, right? Not in half an hour. If I need this to be done in an hour, or there's something, it's while the tasks are driven by orders, when there are variations on the standard order, there's nothing like talking to each other. And at the end, we talk to each other, right? Kaylee, fire away.
Is there not a way that we can build in where we can consult and make our own phone call, or like it's acknowledged to the clerk? Because like if you're at the back of APOD making a couple phone calls, I don't really want to walk up to the front every time and be like, don't worry about that.
I thought it was there. You can put it in the comments, by the way, but I thought it was there somewhere.
You can put it in the comments, but you can go and update the phone call for consult.
Okay, slow down because now you are ahead of me. You got too fast for me. Go back. See, even after all this time, I get lost. Okay, so what you did is you clicked on the phone call, right? Itself?
Mm-hmm.
Can you show me?
Yep. So I'm on the patient. It's hovered. You can see that I'm on the patient because it's blue, but you can also see the patient because it's up here. Yeah. And then ad hoc are a bunch of different forms that we have built into the system.
Ad hoc. Okay, and where did you go to?
Phone call for consult.
Okay. And this is usually the workflow of the clerk, right? Or the nurse.
It is. That's right.
And that's why for us it's ad hoc. It's not built in.
Right. Like when I am logged in as a nurse or a clerk, my activities are going to show up here. I'm going to click on it. It's going to say consult. It's going to take me to this form.
Great. Okay. And then you can update whatever you want. Okay. What happens if I click the telephone? What does it do?
It takes you to the order and you can reorder.
Yeah, but I can't add comments here or anything, right?
You can't add comments there, but I would suggest using this, and I would just say,
Pam called or something. Yeah, perfect. And then the clerk can update because it's easier for them to get to it than to us. That makes sense.
Are those comments on the final chart, or are those comments?
No.
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 And they also won't live. There's, you know how we normally have our trackers right now up in the department for everyone to see? That's going to be called a grease board, and it's got slimmed down information. So you won't see the whole patient name. It'll just have initials. It won't have as much information as we have right in front of us.
Katie, your hand's still up. You have another question?
Yeah, just how do we make it that if we know we're calling at like 7 in the morning or at 5 o'clock after shift change, like how do we enter the consult but then not have it until that time? Just that comment, or?
I would do it in the comments.
But the problem,
Like
the only thing I've seen with that is that, like, I know there has been like consultants who, if we're not calling for a little while, like say you're waiting for something to come back, like you're pretty sure there's no hip fracture or something, but you know the person's had like 5 falls and they're like not doing well, and you know they're coming in anyway, and you want to say like the decision's been made, they're coming in, we just have to sort of, you know, is there a way to like communicate that decision making process, or is it just wait until you have all your information back?
I don't think so. I think you have to, I think in my mind, I place the order when I'm ready to make the consult. Right?
Okay.
And if I've decided that, you know, the wrist x-ray that I made does not change the outcome for the medicine consult, then I'm placing the medicine consult.
Right.
When I'm telling medicine, you know what, I ordered an x-ray of the wrist, I'll keep an eye on it. If it's broken, I'll put it in a cast. If it's not, we're fine, because I know it'll take you 3 hours to get to see it. That's okay. In my mind, that's great.
I've had like consultants come back and be like, you know, this says that the, I don't know, I think one time like a nurse put in their comments that someone was consulted at a certain time, but I wasn't calling until 5 o'clock. And then they somehow like saw that difference and they're like, well, I wasn't called, so that doesn't, like, my time looks bad.
Well, my answer is that then I'll start calling you at 5.
Okay.
Right? But that's my answer. You asking me to hold the patient. You own that time. Like we have to move on as a department from carrying everybody's shortcomings. If you tell me you can't take consults at night, fair enough. I will call you in the morning. But I have decided at 2. And if you don't like that, I'll call you at 2. I have no problem with that. I'm awake. You're asleep.
Okay.
I sound awful there.
But you're right, Kaylee. And when you place the consult order, it's going to be time stamped. And then when the provider arrives, it's going to be time stamped too. So
yeah, Ben's awake too, he says.
Ben will come down anytime.
Yeah.
Absolutely.
Yes.
The credit card is not an issue.
Yeah,
Plus-
I guess it's just like if I only put it in the comments and that I'm not calling till 7 a.m., but I put the consult in at 2 a.m. and then once the chart gets generated, that comment isn't included in that chart anymore on review.
I'll be honest, Kaylee, it's not my problem.
Okay.
It's not my problem. It's somebody else's problem. James, go ahead.
Sorry, weren't you? I sorry, I kind of got a little bit lost in the conversation there. Rachel, you hit the ad hoc though, so did you have to put a new consult in though to be able to put the comment on it?
No, like I put the comment here just in the patient details.
Right.
That would be for if you don't want to complete that consult form, then the nurse or the clerk who has this task can say, oh, okay, I'm going to put in Dr. Tam was called at 1400 and I can complete that task, which gets fired in the system. But to Kaylee's point, when she places that consult, that's locked down. So if you don't want to place the consults until 5 in the morning or 7 in the morning, you don't want it to look bad. I don't know. I would suggest not placing the order until then.
It's bad for them. But remember the other thing, the patient won't turn into consult until you write in that consult order, right? So your status has not changed. So it is your choice if you don't. I would place my consult when I decide to make a consult.
Right.
My
Like, I mean,
consult time.
currently, like when I'm working overnight, I'll click their consult, like I'll change it on the tracker on Meditech, and then I just make my list of things. But the whole point is to get rid of those lists.
Yeah. Now you can't.
So
Now
I
you
was just
can't change the consult unless you file a consult order.
Okay.
But isn't there
but could you?
Yeah. Sorry. Go ahead, James.
Yeah. Sorry. Could you order it under that ad hoc tab that you just ordered under, Rachel, or no?
So,
no.
That's just for the clerks to keep track of it.
That's just
No,
for
so what you're doing-
documentation to
sorry,
say when they were called, how many times they were called, and when they arrived.
So may I just tell you what ad hoc is, James? So at every task, everything is assigned to somebody, right? And completing the consult call is not assigned to a doctor. It's assigned to a nurse or a clerk. So for them, it's built into, you know how you click on something and you get to order more stuff? So if a clerk clicks on a result, they don't get to order more stuff because it's not part of their workflow. It's not part of your workflow to complete a consult. However, you can access it as an ad hoc sort of action by clicking ad hoc and saying, I want to do this, even though it's not my job, but I want to do it. Is that correct, Rachel? Is that how am I explaining it correctly?
Yeah, ad hoc are just forms. They're just documentation. They're not changing the event. They're not changing the status. All of that is going to fire off of an order.
Right. Okay. But I like, okay, not to add more complexities to the discussion, but under ad hoc, like you had the NIH scoring system on there and that kind of stuff. Like, can we still use that and it generates it in the system and then we can link it to the patient or? Okay.
Yes, it will
Like I
link to the
said,
patient
I'm not going to
because
get into that yet because it's getting more complicated than we need. But
James, you haven't figured out how to write a prescription yet. There's still
yes,
a lot to do.
and I'm looking forward to it because yeah, exactly. There's lots and
There's
lots
a
to do.
lot
Yeah,
to
yeah,
do.
because that's
Okay.
the prescription thing will save me so much time though, because right now we're writing them down like 3 and 4 times. It's like ridiculous. I had this discussion with our resident the other day because the residents aren't writing it down, and then you're like, I don't know what you prescribed them. When I go to dictate, like, what did you give them? How many days? What was it? And they're like, oh, I'm like, yeah, I got to write it down. Anyway.
I'm gonna let Maria and then Kaylee, Trelly, and then Kaylee, and then if there's anybody who has a burning question, put it on now, because I want to be cognizant of people's time. We've already been going on for 2 hours, and I'm going to talk about next steps. So Trelly, fire away.
Okay, so you consult someone like medicine at 3 o'clock in the afternoon. When you consult them, is it just medicine or their particular name? Because then they'll say, oh, I'm not taking any more patients. Can you call the person at 5? So you putting in a new consult for
No, you can pick the name of the doc.
and then
Am I right,
then
Rachel?
you have to put another order for 5 o'clock when you call the
No.
next person. So it's the
No.
same. So that one consult is the same, but they call, how do you go back to the clerk to say, okay, you got to call the one at 5 now because the one at 3 isn't taking the patient? Like, is there, when you do, there's so many, complexities with that. Just ease, just
You
to
either
do a
talk to them or
consult
put
is
it in
a
the comments.
process. And is it documented about this 3 o'clock phone call, then a 5 o'clock phone call, then it's all documented in different times.
So there you go. Rachel now found the doc. So I could order the consult now, and Hamid is not coming in until 2 hours from now, right? And I can write it in special instructions, and I can write a consult reason, right?
You don't have to pick the provider either. You can,
Yeah,
you can
but
just
you
say
can.
consult to cardiology. And I don't know, Ben, maybe you can answer that question. Like if we do consult to cardiology now, and then I know it's going to go to your work list. If we just do cardiology, will the next provider coming in, how does that handoff work?
So in terms of that name that you put there in the consulting physician field, basically what that does on our side is that it establishes our relationship with the patient as a consultant. So we would have created lists that have our relationship as a consultant with the patient, and it would flow to that list. So sometimes some docs love using lists like that, and they would have built a workflow. We'll ask you to send a consult with their name attached to it. If you have someone that was initially, let's see, okay, let's just sign this order. We can play it through. Sign this order, and you ask for Hamid now, refresh your chart, but actually it was Tam. So go back to your order. And what cancel and reorder does for you is that basically it knocks that order out and puts a new one in. So go to your consults. Yeah, right click. Cancel reorder. Yeah.
Question, Ben. Why am I canceling and reordering? Why don't I order a new one? Because I spoke to Hamid already.
That would have floated to his list.
Yeah, so I'll just put another one for Mackett, so it flows to Mackett's list.
Then Hamid will have something on his list that technically he's not
Yeah,
seen.
he can take it off his list. I called him, right? His name is actually attached to the chart. Like he gave me an opinion, which is you don't need to consult me now. Consult my service in 2 hours. So if I was getting if a nurse speaks to me anyway, why don't we take this offline? Just because I don't think design is the right this is the right place for design for design process. But we can think about that. But you can modify this, or you can cancel on the order or order a new one. Trelly. Oh, Trelly's done. Kaylee?
You're kind of coming to my point. My point was just like, is this not an opportunity still for, like, I think we're noting multiple difficulties with this consult
Yep.
phase. And like maybe this is an opportunity because like there probably needs to be something that makes it a lot easier for us to say we made the phone call than having to put it in comments and then maybe that being missed and like being actually attached to the order that we already took care of it. And
Kyle is on the call. How about we think about that and see, even if we can't implement it day one, put it on our wish list. Does that make sense?
yeah, and then the other thought is just like is special instructions something we can use, like saying we're putting in the consult now, but I'm not calling until 1700 because of shift change. Like, is that an appropriate place to put that? Because I do think like
I think it is.
Yeah.
I think it is.
Yes,
Does it show up on the nurse or the clerk view, the special instructions, Rachel?
They'd have to go into the order to look at that.
Okay. So if you open the documentation, it doesn't show up, special instructions?
but there just might be an opportunity to maybe like improve that
Is the
process. 'Cause,
consult
like,
reason
yes, I
show up?
agree-
Yes. Not in the ad hoc documentation.
We'll take that, Kaylee. We'll regroup over it. If we can't do it, there's very few things we can do before launch. But if we can't put it for launch, we can probably think of it as a fix post launch. Is that okay?
Or we put it in our note or something, because I agree we want the timestamp, but we also don't want to like sewer our colleagues, right? Like there's a happy balance here.
Yes, you make a valid point. Okay, I will. We'll talk about it and see what we can do. I have another couple of questions about consults that I've developed in my mind, but I'll talk to Kyle and Rachel after. Okay. Any burning questions? Rachel, Kyle, and Ben, anything on your mind that we need to talk about?
I don't think so. And I know we're over as well, so it was a really robust discussion. I think these sessions are really useful and it gives you a chance to deep dive. We are still about a month away. So if folks are interested in one more informal gathering a bit closer to the go live, we can look at arranging something. And then there's also something called Favorites Fair. And I know that was discussed and I had jumped off, I think, when there was probably a bit more discussion. But you're going to get your chance to put your hands into what we call the production environment and do a lot of customization for your own workflows. And then the only other place that you can do a little bit more practice is the sandbox. And you heard that's coming as well. So lots of opportunities coming up. Please do take them and then reach out if you got any questions.
Okay. Rachel, Kyle, anything that we need to say, anything we didn't say right, anything that you think we need to highlight?
No, Kyle left me, but yeah, I mean, feel free if you get into the sandbox and you don't know how to do something, you can email me, Rafi, you can message us on Teams, anything.
Absolutely.
Just we're here to help.
Perfect. So next steps, those of us who didn't complete their training, please complete your training. What I have done, this is the week before launch, this is my calendar. I have booked it, I'll distribute them. I haven't distributed them less. I have 3 drop-in sessions. I'm going to be online on a Teams call. Everybody will have the link. If you have burning questions, you think I can help, jump in. If Rachel or Sam or Laura or anybody of our team is free, they're welcome to join us as well. No structure to them, just a conversation. How do I do this? How do I do that? I'm getting stuck with this. And then the 4th day on Thursday, I also have a get together, but this is strictly for the people who are working that weekend. Created a group from the guys who are working that weekend in all the EDs and the UCCs so that we can just make sure that we are solid for launch day. So I've put a time every single day in the last week. I'm working Thursday night, so I can't do Thursday and Friday. And then I'm working both. Like I'll be there for launch and I'm going to be in the ED. And I understand I know that I'm going to be there early. I'm going to stay there late, and I'm going to try to support people as much as I can. If you work on your MacBook, I am happy to remote in at any time if you have a problem and try to help you from home. I can do that. I can't do that on hospital computers, but I can do that if you're working on your MacBook. You can let me in and I can help. This is the plan. I think we've come to the last stretch. Anything else guys? Awesome. With that, I want
Thank
to
you very
thank you.
much.
Thank you so much, guys, for taking the time. Thanks, everybody. Rachel, we can debrief you and I in a minute, because and Ben, if you want, I just I'll just call and make a Teams call. Bye, Adrian.
Thanks, buddy.
Take
Thank
care.
you.
Thanks so much, guys. It was great.